good evening. My name is Darwin Chimba. I'm the Director of Operations for the Association of East African Neurosurgeons, and I'm a medical student from Olabatoke University School of Medicine. So this evening, we are happy to continue with the Neuro Oncology course that we've been doing for the past 3 weeks. And today we have a presentation from Tunde. So before we begin our presentation, we're going to introduce ourselves. The panel is going to introduce themselves, and then I'm going to call upon the presenter for this evening to begin the presentation. So I'm going to be calling the names as they appear on my screen so that people can introduce themselves. So we can start with Bejo. Bejo, please introduce yourself.
Greetings, everyone. I'm Takutin Dogmo Bejo, senior medical student at University of Buya, member of IFAN. I'm glad to be here.
Thank you so much, Bejo. Okay, Dr. Chibuike.
Hello, everyone. Good evening. My name is Chibuike Kumai, medical doctor from Lagos, Nigeria. Glad to be here.
Thank you so much. Then we have Dr. Ulrich.
Hello, everyone. I'm Ulrich Sidney, founder of the Association of East African Neurosurgeons, and thank you very much for being here today, and we excuse ourselves for the delay.
Thank you so much, Dr. Ulrich, for that. Then I'm going to call on the presenter, so you're going to introduce yourself and begin the presentation. Tunde, you can begin.
All right, thank you very much. I am Tunde Olabatoke. I'm a fourth-year medical student at the University of Lagos, Nigeria, and I really want to thank IFAN for giving me this opportunity to make my presentation. I will try to share my screen now. Okay, I think I'm not able to share my screen. I think I need permission to do that.
Okay, let me just allow you to do that. Okay, sure, you can go ahead.
All right, thank you. All right, I believe I'm audible enough, and I believe you can see my screen now.
Yes.
All right, thank you. So today I will be making a presentation on the third case for the Neuro Oncology course that has been on for a while now. And like I said earlier, I'm Olabatoke Tunde from the College of Medicine, University of Lagos. So the plan for the presentation is that we'll first have a case presentation, and thereafter we'll have a literature study about the case, link it back and forth so that we can better understand the case. So I'll begin with the case presentation, and as much as possible, I would really love our participation so that we can make this presentation what it ought to be. So I try to break down the case, get it better and understand it, and I hope I'm able to achieve that. So we have a patient that is age 35 years old, and he is a male, a 35 years old patient who is a male, and he presented with an initial tonic-clonic seizure and headache. For how long? For 3 months. For 3 months. So he presented for 3 months, and the past medical history is otherwise unremarkable, and that means that there is no any particular significant past medical history. And on clinical exam, the patient is awake, oriented, the cranial nerves are fine, the motor strength also is fine, except for a mild left arm pronator drift. So here is our case presentation. Let's just read it through now. So we have a 35-year-old male presents with an initial tonic-clonic seizure and headache for 3 months with past medical history that is otherwise unremarkable, and on clinical exam, the patient is awake, alert, and oriented, and has intact cranial nerves, intact motor strength, except for a mild left pronator drift. So I would like us to just briefly analyze our case. So from that case presentation, I think these two this is really important that we look at them. So number one, we have a tonic-clonic seizure and headache for 3 months, and we have a mild left pronator drift. So I don't know if anyone can help us. So looking at this, what can we say about our patient? What does it mean by the patient presenting with a tonic-clonic seizure? How does the duration come to play here? And the mild left pronator drift, I don't know if anyone can help us with this.
Come on, people, let's not call names. I'm sure everyone here has an idea.
Okay, so hi, good evening. Hello, good evening. Can anyone hear me?
Yes, we can.
Okay, great. So the patient has a mild left pronator drift. So pronator drift is a pathological sign that is usually seen on clinical examination, neurological examination, and usually points to a lesion or a problem in the spinal tract. So usually of contralateral side. So he has a left pronator drift. So most likely has problem with his right cerebral hemisphere. Then he also has a tonic-clonic seizure and headache for 3 months. So the 3 months most likely is pointing to something of a long duration, probably a mass effect of the tumor.
All right, thank you very much. So I will just go on now. So tonic-clonic seizure, also known as grand mal seizure. So from the name, it has a 2-part. So we have the tonic phase of the seizure, where the patient experiences the muscle stiffening, and we have the clonic phase where there is the jacking. So if you look at the tonic phase, there's muscle stiffening. The patient could experience an epileptic cry due to the forceful exhalation of air from the lung, sinuses, and at the clonic phase, they experience jacking at the muscles, blinking of the eyes. And if you look at the post-ictal convulsional fatigue, the patient might just be lying down, restless, and unconscious. So, also known as grand mal seizure. Mild left pronator drift, just like it has been said, it's also known as a pyramidal drift or bar sign. It is named after Alexander Bach, who first described it. So it is a neurological sign that is usually seen during the clinical exam, and it usually indicates an upper motor neuron lesion. So just like we have other signs of upper motor neuron lesions, like the Babinski weakness and all. So pronator drift is a sign of upper motor neuron lesion, or it is a sign of a corticospinal tract defect, just like it has been said. So our patient has a mild left. So normally, when you ask a patient, or a normal patient, to stretch for the 2 hands with the hands supinated, that is the palm. So the normal patient will be able to do that confidently for a long while. But in an abnormal situation, we have some patients who are not able to do that. So while they stretch forward the 2 arms and with their palms supinated, as time goes on, the, the, the part that is affected, and it is usually contralateral. So it means for a patient that is left, that means the defect is at the right part of the brain, the right side of the brain. So it's usually contralateral. So you realize that such patients are not able to keep their hand in a supinated posture. So the hand tends to go down and it's becoming supinated. So this is just an illustration of that. So a patient has this clinical presentation. So from there, can we have some differential diagnosis at this stage? Anyone helping us with some differential diagnosis?
Before going to the differential diagnosis, like for me, with this presentation, a patient with the symptoms of raised intracranial pressure, seizure, headache, and the signs of upper motor neuron lesion. So the first thing I'll think of is space occupying lesion, based on the elements I just mentioned. Now, for the different diagnosis here, I'll divide them, like talk about neoplastic causes, talk about vascular causes, infectious causes. Now, for me, the first thing I'll think about here is a neoplastic cause. Now, since the patient is a 35-year-old patient, so I'll think more of a metastatic lesion in the first place with this presentation. Now, as next differential, I will think of another malignant tumor in the brain based on the fact that the headaches have been there for just like a subacute duration, to mean that there's a kind of a rapid expansive process in the brain. And precisely the tumor that I would think about here is a tumor that affects the white matter, because here this patient is having seizures, meaning that there's probably a lesion at the level of the cortex, and the fact that the patient is having the pronator drift, meaning that it affects more likely the white corticospinal tract, which are found at the level of the white matter. Now, other differentials could also think maybe of a brain abscess and encephalitis, or maybe toxoplasmosis. Thank you very much.
All right, thank you very much for that contribution. So actually, we have a space occupying lesion as one of our differential. It can be an infarction or hemorrhage. It could be as a result of cerebritis or an encephalitis. It could be. Okay,
Yeah.
It could be a low-grade glioma. It could be an ependymoma, multiple sclerosis, and it could be other cerebral neoplasms. So now we need to bring this down. We need to narrow it down. So what should be the next thing that we would do in order to come down to a particular diagnosis in our patient? What should be our next step of action in order to come down with a particular diagnosis in this patient?
So looking at our differentials, one of the things that we can do is imaging. So we can have a CT scan or MRI, so that we, especially in the case where we are considering a space occupying lesion or a tumor, we can have imaging would be very helpful. And other modalities of imaging with CT scan and MRI can also be employed. But basically that.
All right. Thank you very much, Darwin. So just like he has said, have imaging like the CT scan or MRI, and it can be both. Could have diffuse tensor imaging, PET, MR spectroscopy. We could have a CSF microscopy and cytology in case of CNS lymphoma. I think having a CSF microscopy or cytology could be helpful. And also have a plasma electrolyte analysis, because the patient presented with her a tonic-clonic seizure, and it could be as a result of a number of things, and we could have a blood glucose level, because diabetic encephalopathy can also result into a seizure, but in our patient, there is no any past medical history that is pointing towards diabetes, and we could also have CSF, glucose, microscopy, and electrolyte analysis. So I think these are some of the possible things we can do. So on imaging, we have this result on imaging. So we have this result. So I think the first question here would be, what kind of imaging is this? So just looking at this, is it a CT scan? Is it an MRI? Is it an MR spectroscopy? A PET scan? Or what? And can we try and locate some of the defects we could see on the imaging? So I would love if someone can help us to analyze this imaging first by telling us what type of imaging result is this, and help us to analyze some of the findings we could see on the imaging. All right, is anyone helping us out?
Yeah, I think I can try.
All right, thank you.
Okay, for the for the imaging A, I think A is MRI T2 weight, based on the fact that the CSF appears hyperintense. So there you could have a lesion at the level of the frontal, at the level of the, I think it's frontal lobe, temporal lobe.
Okay. Okay.
You have a hyper intensity there available, which is like the borders are kind of you could yeah, at the level of B you have kind of because here the B is the T1 weight, it's an MRI, but you have kind of a two intensities there. You have one which is hypo intense, and another one that is I don't know, between hyper and iso, like an iso intense. And you could have a little bit of mass effect, because when you come at the level of the posterior horn, of the lateral ventricle, you consider there's a little bit of effacement at the level.
Okay.
I think that's fine. Thank you.
I think I can't hear you anymore. Can anyone still hear him?
Yes, no, I was saying that no, even at the level of C, you could still have a mass effect too, but with the imaging C, you can appreciate the mass effect at the level of the anterior horn and the posterior horn of the lateral ventricle. That is on the left, on the right side,
Okay. Okay. Okay.
Thank you.
All right. Okay. Thank you very much. So I think I'll just proceed from here. Thank you for that contribution. So this is an MRI findings. So these three images, A, B, C, are MRI findings, just like it has been said. And if we look at the images, image A and B shows a T2 hyperintensity. And if you look at the right side here, you can see the an hyperintense tumor that is not really differentiated, not the border is not too clear. And if you look at B also, you see that with a little bit of mass effect at the posterior horn here actually, and it appears there is a little bit of peritumoral edema, but not really too clear there. And the image C is a T1 hypointense. You can see here it is not really is hypointense, and this is actually at the insula, you can see. at the insula, the right temporal lobe, the on-course, the inferior right temporal lobe. And so if the imaging result here does not show any enhancement, and that is because this kind of tumor basically most of the time does not show any difference on enhancement. So I think we will look at that further as we continue the presentation. So I would not love to talk about it now, because that may give us a clue to what the diagnosis is exactly. So, okay.
Yeah, sorry. Yeah, I have a question. Yeah, before you move on, image A and B, you say T2, yeah, T2 images, right?
Yes.
Yeah. So what kind of sequence is the image B? Because normally you'd expect CSF to be white in T2 sequence. So what kind of T2 sequence is image B?
Okay. If you look at,
you have fluid attenuation there.
That's an image B.
So you have, when you compare C with B, what you see is that there's fluid attenuation. So it's a flare, fluid attenuation with inverted recovery. What I mean by this is, if you look at image B, you can see some of the edema, right? And then when you go to image C, it has disappeared.
Okay. I don't know if you get what Dr. Ulrich is saying.
Yes, I do. I just wanted you to clarify for general.
Okay. So, are you clarified now?
Yes.
All right. Thank you. So, I think we'll just continue from there. So we already have a differential diagnosis, but I think we need to narrow it down. So based on the MRI imaging results we just saw, can we come down to a diagnosis, or do we need further investigation to come down with a diagnosis? I would really love a comment at this stage. So can we really have a diagnosis now, or we need some other investigation?
Hello.
Hello, good evening.
Yeah, I think that we can go maybe with an MRI spectroscopy as for the investigation.
Okay, so that means what you're trying to say now is we can't at this stage come down with a diagnosis, right?
Yes.
Okay, and any other comments?
Well, what I think is that I think it's possible that we can possibly eliminate some of the differentials and then go ahead to do other investigations to come up with a definitive diagnosis.
All right. So, okay.
I just want us to wait. Hold on here. Hold on. So when we say a space occupying lesion, there are a few things that are cited here that are space occupying lesions as well. I think it's important to make that difference, right? When we say a space occupying lesion, a tumor like a low-grade glioma, an ependymoma would be a space occupying lesion. When you say other cerebral neoplasms, so I think maybe what you should have done was put them at a different bullet point level so that they should be below a space occupying lesion, right?
Okay. I think I get that.
Because as the word, it's really as simple as it says, like there's something, remember that within the cranium, we have the brain parenchyma, we have CSF, we have blood, which is within the vessels. And then what happens is, if you remember the Monroe-Kelly doctrine, is that when there's an increase in one of the components, then there needs to be an adaptation from the other components. So a space-occupying lesion is something that comes and adds itself to this stable equilibrium. So when you have something like a tumor, that is a space-occupying lesion. It's occupying some of the space within the cranium, right?
Yes, yes.
So what I'm saying here is when you look below a space-occupying lesion, when you say low-grade glioma, that is a space-occupying lesion. Ependymoma, that is a space-occupying lesion. Other cerebral neoplasms, that's a space-occupying lesion. Now, when we talk about multiple sclerosis, cerebritis, and encephalitis, those are not space-occupying lesions, right? So you should have ordered this in such a way that it makes more sense to yourself and for the viewers. But then let's go ahead. And maybe I think at this point, perhaps we can even start thinking about how to eliminate some of these diagnoses, because from what you've told us, it's possible to eliminate quite a few of them. Let's just go ahead. Yeah.
All right. So actually, it's possible to eliminate a few of them, like we said. So but we actually need some further workup in order to eliminate some. So if we do something like a biopsy, it can tell us the type of cells that are involved, the structure, the arrangement. I think from there we can actually get a lot of information. And we might also want to do more imaging, just like I said, like PET, the MR spectroscopy, and but this might be quite difficult in and we can consult CSF cytology or microscopic result in case of an infection. So in case of an elephantiasis, sorry, in case of an encephalitis or cerebritis. So I think doing the CSF cytology or microscopy can really help us, or a bacterial infection or any. So and can do a plasma electrolyte analysis for certain markers. As you know that certain tumors have specific markers to them, and we can actually consult a neuro oncology consultant. So actually from the case we are given, there are no any other result that was shown. They carried out some other investigation. So if and another thing I want us to
Tunde, sorry for stopping you there. So right. I just want us to be a bit more specific in saying what we're looking for and why we're looking for that. So from the audience, perhaps can anyone say for any of the modalities, why would we do this workup? What are we trying to eliminate, or what are we trying to diagnose, and what will we be looking for in the results? So I understand that, yes, we'll do CSF cytology and microscopy, but what are some of the things that we can get from the cytology that can orient towards a specific disease among the differential diagnosis? Anybody in the audience? So remember that there's, in the diagnosis, we had a few inflammatory diseases. We had, for example, multiple sclerosis, right? So if we're talking about multiple sclerosis, what do we expect the CSF to look like? What is the composition of an inflammatory CSF? Okay, right. So,
hello?
Yes?
Yeah, sometimes like on microscopy first, before you can go into cytology and microscopy, usually with multiple sclerosis, for example, CSF may be clear. Of course, we have to start with the microscopy. You observe, you look at the color and other factors or other characteristics of the CSF. So usually with multiple sclerosis, it's clear. And I think also with a good number of the differentials that we've listed, it may be clear, unless if it's if there's some parts being produced where it's a purulent kind of inflammation. Then in the case of multiple sclerosis, like you have said, the cell count may be normal, but the total proteins usually may be increased, if I'm not mistaken.
Yeah, so you've given some of the key elements. Just as a quick reminder, when we extract cerebrospinal fluid, like Darwin clearly stated, we're looking at things like at a microscope, we're looking at whether the fluid is clear or maybe cloudy. In the case of an infection, a bacterial infection, we're equally looking at the pressure, the opening pressure, which can be very interesting here. Imagine if you have a space occupying lesion and a patient that has signs of intracranial hypertension, even asking the CSF for CSF analysis, that is by lumbar puncture, you have to be very careful. So always keep that in mind. But more importantly, a disease like multiple sclerosis, which is an autoimmune related disease, will have an inflammatory process. And if you go back to your basic physiology, pathophysiology, when you talk about inflammation, right, what you're seeing is numerous processes involved. You have a vascular phase, you have a cellular phase. If you think about the vascular phase, you think about everything that leads to transudation, right? You have that vasodilation with elements that lead from the vessels into the interstitial fluid. This is very important because then you remember that when you have inflammation, you have production of proteins, and those are those proteins for the inflammatory phase that will find themselves increased in the CSF. So one really important component is the increase in proteins. If we're during a flare up, then we'll expect equally an increase in the cytology, the cells. But we have to go further. When we're talking about CSF, we always need to go further and explain what kinds of cells would we see increased. So the next question here would be really quickly, what kinds of cells are increased, for example, in multiple sclerosis versus, say, meningitis, for example?
Yes, I'm getting you, Ulrich, Dr. Ulrich.
So the question I asked is, how is the cytology? If you're thinking about here, we said we could have thought about multiple sclerosis, we could have thought about encephalitis, right? So what would we expect the cytology to be like?
In case of multiple sclerosis, the cytology could be normal, or you could have just mild pleocytosis.
Yeah, and if it's the case, then what kinds of cells, what inflammatory cells would be increased?
I think you have more of a lymphocyte.
You're right. Remember that when you have anything that is acute, and that is related, for example, to bacteria, often what you get is neutrophils. When you have any process that happens in time, like things that give waxing and waning, you're going to get a lot more from the lymphocytic population. But it is true that when we're thinking about multiple sclerosis, it's more proteins and less cells, autoimmune diseases, like Darwin said initially. So that is something that we need to keep in mind. So whenever you're seeing these workups, ask yourself all these questions we just did, like why are we asking for this workup, and what are we looking for? Okay, Tunde, back to you.
All right. So just like Dr. Ulrich has said, we need to find out why exactly we are carrying out some of this investigation and the possible findings that we could see there. But it's quite unfortunate that from the case that I was given, there was no any further result that was shown. So although they carried out other investigation, but the results were not shown. So it appears their diagnosis was based on the imaging result. So, and obviously, I'm sure it's not. So they probably carried out some other investigation which results were not shown. So from differential, let's go back to our differential diagnosis now. From our differential diagnosis, if, for example, we carried out our CSF cytology and obviously we can't find any form of an increase in inflammatory cells like the lymphocytes, the neutrophils, so probably we are ruling out multiple sclerosis, we are ruling out encephalitis. There's no any form of infection, so we can rule out encephalitis, and there is no any history of trauma. So there is no any history pointing towards infection on hemorrhage, and probably on an hemangiogram, we can't find any vessel issue, so we can actually rule out the infection or hemorrhage. Left with the space occupying lesions, which are like the ependymoma, the other cerebral neoplasm, and but actually for this particular case, as we discussed in the literature, we realize that the major means of diagnosis is through the biopsy, because the way the tumor behaves is usually through the biopsy. So the question is, what is, so I don't know, I feel probably you might not be able to answer this question since we don't have results for other investigation. Am I correct with that? Hello, can you hear me? Am I right that we probably can't give a particular diagnosis since we don't have result of other investigation that was carried out? Am I correct with that, or does anyone have a comment?
Go ahead. I think the MRI gave some information, but for this level for medical students, yes. I would just say that the reason we would eliminate infection or any kind of hemorrhagic process is because when you think about a vascular disease, you think about time. It happens in a very short period, right? Always go back to your history. That's the reason when you said Tunde, when you said in the document, they didn't give you further information. It's because you're supposed to narrow it down based on history. So infection, hemorrhage is something that happens in a very short period. And if I'm not mistaken, this patient has had presented the symptoms, you said for 3 months, right?
Yes, 3 months.
So 3 months, it's very unlikely that will be an infection or a hemorrhage. And if you're thinking about something like multiple sclerosis, you're thinking about a history of waxing and waning. What that means is you have a patient that has flare-ups. The patient has certain signs, right? And then they come acutely and then they disappear. They come acutely and then they disappear. Well, now, depending on the kind of multiple sclerosis, whether it is relapsing, remitting, you will have a different kind of pattern. But at the end of the day, this is a patient that shows acute signs, and then during a period, they have no problem, and then they show acute signs again. So again, just with that history, you can eliminate multiple sclerosis, you can eliminate cerebritis and encephalitis, you can eliminate infection or hemorrhage, and you're left pretty much with things like tumors, right? Now with the tumors, you'll be asking yourself, the really quick way of doing it is just starting with the MRI. But if you don't have classifications from MRI, then maybe what you can do at the very least is to ask yourself, is it a primary tumor or a secondary tumor? You would think of a secondary tumor if you have a primary or a history of a primary, or then it's a secondary. So that way we've already limited it quite a bit.
Yeah, exactly. So actually, if we go back to the case, we realize that the patient history, he presented with those symptoms for 3 months. So, and if that were to be a secondary tumor, I believe it would have not stayed for that long. And just like Dr. Rick had said, so we are left with the tumors basically, and If you also look at the imaging result, looking at the area, that's the major areas that were affected, the temporal lobe, the inferior part of the frontal lobe, the insula. So actually, there is a particular tumor that is usually, most of the time, usually occurs in that area. And if you also look at that tumor, you realize that there is it does not cause any form of a midline shift. It occurs part of the lobe, that's the right part of the brain. So this characteristic actually points towards a low-grade glioma. This characteristic points towards a low-grade glioma. And if you could recall, I think I made mention of something about contrast enhancement, that contrast enhancement results were not shown. And that's because this tumor usually does not show any difference on contrast enhancement. So, and that's what the contrast enhancement image results were not actually shown. So the diagnosis for this case is a low-grade glioma based on those information. So I think we are good. Hello, everyone. Are we good? Can we continue now?
Yes, go ahead. Go ahead. Thank you.
All right. So can we just mention some of the probable method of management or treatment for this patient? Can anyone help us with some of the probable management?
Yeah. So we have a few people here who are working on the low-grade glioma scoping review. If anyone is on that study, what are the ways that we can treat low-grade gliomas? Darwin, I think you're on that study, right? When
Yes,
you're
I am.
extracting data in the management, what were some of the ways we thought about treating, we were looking for treating low-grade gliomas?
Okay, so first of all, we can classify the management options as the medical or surgical. Under medical, we have chemotherapy, which can be used. Other than that, we can see that this patient is also having convulsions. We can also give some anticonvulsants. Then we can also look at the surgical options, rather the surgical management of these tumors.
All right, Darwin. So just like Darwin has said, I think I'll just rush over about them more detailedly when we get to the literature part of the presentation. So we could have it can be divided into the medical treatment, chemotherapy, radiation, surgical. So for the medical, you want to give anti-epileptic drugs, anticonvulsant, and for symptoms of peritumoral edema, you want to give steroids. So the basic chemotherapy that is usually used are the temozolomide, procarbazine, lomustine, and vincristine. And we also may want to give radiation therapy. And this actually can be done either alone or in combination with a surgery. And we have the surgical method of treatment. So we'll look at this in more detail at the second part of the presentation. So I'll be quickly talking about low-grade glioma, and I will be using the following content. We'll look at the introduction, the epidemiology, the classification, etiology of causes, the clinical features, diagnosis, the prognostic factors, and the management of low-grade glioma. So looking at the introduction, so normally we know that the clear cells are they are part of the brain cells, and they are helping cells. So gliomas are basically the primary tumors that arise from these cells. They arise from clear cells of the central nervous system, and they comprise about 30% of all brain tumors and central nervous tumors, and about 8% of all malignant brain tumors. So they're classified into either a low grade type or a high grade based on the WHO grading system, and we also classify them based on the cell types. So the low grade glioma, according to the WHO grading system, actually in grade 1 and the grade 2 type of WHO grading system. So looking at the epidemiology, low grade glioma actually accounts for approximately 15 to 20% of primary brain tumors in adults, and generally it occurs in white males and in younger patients. So if we look at the case that we had, we realize that our patient is 35 years old. So it usually occurs in younger patients, usually in their fourth decades, at least around 40 years of age, compared to an high-grade glioma. For those that were around for the neuro case 2 that we had last week, we realized that that occurs in a 55-year-old patient. So high-grade glioma normally tends to occur more in older patients compared to low-grade glioma, which tends to occur in our younger patients, as you can see from our case presentation. So these are some of the clues actually that can lead us to a diagnosis. So there is no known hereditary factors for this condition, but it's usually common in neurofibromatosis type 1 and tuberous sclerosis patient. So it's usually common in this patient. And we know patient who has neurofibromatosis and tuberous sclerosis tends to come down with a lot of CNS tumors. Based on WHO classification, so we have the grade 1 and grade 2 tumors that are usually involved. So for the grade 1, we have pilocytic astrocytoma, subependema giant cell astrocytoma, have the pylomyxoid astrocytoma, the pleomorphic santo astrocytoma, the diffuse astrocytoma. So for the diffuse astrocytoma, we could have the fibrillary, protoplasmic, gemicitic. So the gemicitic is more prone to become malignant. Let's take note of that. And we also have the oligodendroglioma, the oligoastrocytoma, the gangliogliomas, the gangliocytomas, these embryoplastic neuroepithelial tumors. So I would like to mention this, that the classification of low-grade glioma actually still remain a controversial, because if you check different literatures, you realize that it appears that different authors tend to have different classification due to the varieties of the subtypes and the different types of cell lineages and the histopathologies. So don't be surprised checking other literatures and you're seeing like a different kind of classification other than the one that is shown here. So there's still a little bit of controversy in the classification of low-grade glioma. So I'm hoping that the WHO next classification review probably will be able to solve this. Looking at the etiology of causes, so there is no known particular cause, but like we said, they do occur more commonly in neurofibromatosis type 1 and in tuberous sclerosis patient. And the cause tends to be multifactorial, and so it could be genetics, as we look at the next slide, and it could be as a result of immunologic causes or infectious factors. So it tends to be multifactorial, and there is no any particular cause. For the genetic part, IDH1, that is isocitrate dehydrogenase 1 and 2 gene mutation, has been implicated in actually, it occurs in actually 70% of patients. So most patients with low-grade glioma tends to have an IDH1 and 2 gene mutation, and they could also have a combined loss of the short arm of chromosome 1 and the long arm of chromosome 19. So they could have a chromosome 1 short arm and chromosome 19 long arm co-deletion. So, and this feature actually is pathognomonic for oligodendroglioma. So when you do a genetic analysis and you realize that there is a co-deletion of the short arm of chromosome 1 and the long arm of chromosome 19, it's usually something that is seen in an oligodendroglioma. And then we could also have a mutation in the CIC and FUBP1. It's also commonly seen in an oligodendroglioma. And we could also have P53 or inactivation of the atreus or both. And this actually is usually seen in in astrocytoma. So these are the major genetic causes that could result into a low-grade glioma. So looking at the clinical features, so most of these patients will present with epilepsy, as we have seen in our case. So our patient has a tonic-clonic seizure, and they will present also with headache. So the patient has a tonic-clonic seizure and headache for 3 good months. And normally, we tend to see, they tend to come down with a normal neurological examination. So if you look at our patient, you realize that the cranial nerves are intact, the motor strength also is intact, except for the mild left pronator drift. So most of them tends to come up when on clinical examination, they tends to appear normal, except, and if it's present, it's usually very mild, and it tends to cause a focal neurological deficit, and that's because these tumors are not so aggressive. So they are not so aggressive compared to the glioblastoma, as we look at at the last presentation. And there could be papilledema, and there could be a neuroendocrine disturbances. So these are some of the basic clinical features. But let's take note of the fact that they usually come down with headache and epilepsy. So looking at the diagnosis. So to diagnose this patient, as you can see that it appears we find it somehow very difficult at the early onset. So the clinical symptoms is very, very important. It's very, very important. So the patient tends to present with seizure and headache commonly. And then also we can't overemphasize the importance of clinical examination, but just like we have said, that most of these patients tends to appear normal on clinical examination. Now, another important thing that can really help in the diagnosis is the location of the tumor. So basically, low-grade glioma tends to occur at the temporal lobe, the posterior frontal and anterior parietal lobes, and specifically at the supplementary motor cortex and insula. So this tumor tends to occur at this region of the brain. Kind that is looking at the presentation of the patient and looking at the location of the tumor, you can probably start thinking or placing your mind on a low-grade glioma case. And imaging also is very, very important in the diagnosis. So we could have a CT scan, we could have an MRI. So we could have the T-weighted, usually show an hypo-intense to iso-intense, and we could have the T2 weighted group usually show the hyper-intense. And we could have other imaging like the PET and MR spectroscopy. So just like I made mention of, they rarely have contrast enhancement. So on contrast enhancement, there may be no changes from the initial image result. So most of the time, when you do contrast enhancement, you might not really find anything different, and you might need to consult a neuro oncology consultant. So that is very, very. So these are some of the things that can really help in the diagnosis of low-grade glioma. So looking at the prognosis factors. So Chang and others in 2008 proposed a pre-operative grading scaling, and this actually shows a poor prognostic factor. So for a patient that is over 50 years of age, they tend to have poorer outcome compared to those that are below, and patient with a KPS score that is less than 80, and when the tumor is located at the eloquent part of the brain, so the patient could have a poorer outcome, and when the diameter is greater than 4 centimeter, so the patient could have a poorer outcome. And the good prognostic factors would be when there is a co-deletion of the short arm of chromosome 1 with or without the deletion of the long arm of chromosome 19. So it usually tends to have a good prognostic factors. And patient with oligodendroма, and if you could recall, I made mention of this, that patient with oligodendroma tends to have a co-deletion of 2019. So oligodendroma patients have a better prognosis than astrocytoma patient. Let's take note of that. So I just like to show some things from this image. So if you look at this image, well, we realize that low-grade glioma tends to occur at like the frontal lobe, the temporal lobe, the insula at all. And this is, if you look at this image very well, you realize that this is a post-contrast image. If you can see my cursor, so this is a post-contrast image, and it appears there is no particular difference. So that's why most of the time there is no post-contrast enhancement in the image. And if you look at this other side, it's just telling us again about the location of the tumor, that it tends to occur more at the temporal lobe, the insula, and going forward into the inferior part of the frontal lobe. So now, like I said, biopsy is very important in the diagnosis of this case. Biopsy is very, very important. And if because this cell, they tend to have different cellular structure on analysis. So for oligodendroma, if you look at this structure, you tend to have a cell that is looking like a fried egg, and you see the nucleus somehow at the center and with a clear cytoplasm surrounding it. So and you see a kind of like a chicken wire capillary pattern. So I think the molecular pathologists are important as physician, that you probably also take note of this. So and in pilocytic astrocytoma, from the name pilo, you tend to have like something like pili. So we usually call that recenter fibers. So you look at the cell, you see a kind of fibers that is just crossing around in between. So these are refers to as recenter fibers, and it's usually seen in pilocytic astrocytoma. And if you look at this tumor on gross, it is usually solid. It's usually solid and cystic on gross examination. So if you look at gematocytic astrocytoma, the cell tends to be eccentric. They're usually located at the side of the cell. So and they plasm, and the cells are the nucleus rather. The nucleus are located at the side of the cell. So these different features can actually help us in the diagnosis of a low-grade glioma. That's why the idea of biopsy is very important. So looking at the management, like we have mentioned, so you want to treat the seizures. So by giving anticonvulsant or anti-epileptic drugs, and the commonly used ones are lamotrigine, levetiracetam, and topiramate. And the question is, can you give prophylactic anti-epileptic drugs? Actually, it is not indicated, and that's because prophylactic anti-epileptic drug has not really shown to be preventive in those patients eventually coming down with seizures. And you probably just expose the patient to the side effects and toxicity of this drug by giving them one, since it actually will probably not prevent those patients still eventually coming down with seizures. And you can also administer steroids for the peritumoral edema. So for the chemotherapy, well, the exact rule of chemotherapy is not yet defined, and the two basic regimen that is used is temozolomide and a combination of procarbazine, lomustine, and vincristine, like I earlier made mention of. We also have a radiation therapy. So I want us to take note of this, that radiation therapy may lengthen the progression from the free survivor. It may lengthen the progression-free survivor, but not the overall survival of the patient. So it may lengthen the PFS, but not actually the overall survival of the patient. And there's the higher doses of radiation improve outcome, that is no. So the higher dose of radiation does not improve outcome, but rather it tends to expose the patient to a more toxic risk due to radiation. And we also have a stereotactic surgery instead of a whole brain radiation. So this has proven to be really effective in the treatment of low-grade glioma. So stereotactic surgery, radio surgery may be used as primary. So based on the clinical, so actually the management is individualized. So it is based on the presentation and the nature of the tumor that will determine does this patient needs does it need a surgery or radiation therapy alone is enough, or do I need to have a surgery then give additional radiation therapy? So it depends on the individual patient. So and then we have surgery. So the goal of surgery actually is to ensure total resection. That's the aim. But at the same time, you want to reduce causing a neurological deficit. So, but the goal is to ensure total resection, and it's highly recommended for polycystic astrocytoma, and it is less useful for widely disseminated or multifocal tumors, and you would agree with me, because if the tumors is widely disseminated, if you would want to have a surgery, you might cause more harm than good to the patient. So for a widely disseminated tumors, you want to have radiotherapy and chemotherapy. So I would like us to take note of this, just like I made mention of that. The management is individualized and is based on the tumor histology, the molecular characterization, and the patient risk factors. So, and the goal is to increase the overall survival and to reduce the declining neurological deficit. That is the goal of management. Um, um, Looking at the surgical techniques, like I said, the aim is to have a total resection, because patients who are operated and you are able to remove the tumor completely, they tend to come down with a better post operative they tend to be better and come out with the better prognosis factors. Then we also want to have an electrostimulation mapping. So this is usually done for the eloquent area. So you want to map the areas in order to avoid damaging the eloquent areas of the brain. So electrostimulation mapping is very important when you need to operate the eloquent areas of the brain. So I would like to just quickly run through this algorithm that is provided by Cancer Network in 2017 of the management of low-grade glioma. So when we have an MRI that is consistent with low-grade glioma, the aim is to have a maximum and a safe surgical resection. That is the aim of the surgery. And like I made mention of, the molecular analysis is very, very important, because that will let you to know the aggressiveness of the tumor, to help you to know the prognosis for the patient. Just like I said, a patient that has a short arm of chromosome 1 and long arm of chromosome 19 co-deletion tends to have a better prognosis compared to other patients. And so you want to have a gross total resection depending on, so if the patient has a low risk after a gross total resection, you may just want to observe the patient rather than going for any other. So for a low risk factor patient, so you may just have a total resection and you observe. So you probably may not need any other therapy after a gross total resection. So why for patient that has an high risk factor, with and for patient that you have a subtotalization, probably due to the location of the tumor, maybe in eloquent areas, you are being careful enough, you don't want to cause any harm, so you are not able to totally resect the tumors. So you may want to think of having a radiation or a chemotherapy in addition to surgery. And like I said, radiation itself can be a primary method of management, especially in patient that has a multifocal tumor or a diffuse kind of low-grade glioma. So I would like to just bring to our notice the idea of genetic therapy. So Miller, Alexandra, and others in 2019, they carried out the research, and they realized that there is uh, there is a circulating tumor DNA that is found in so the title of the paper is Tracking Tumor Evolution in Glioma through Liquid Biopsies of Cerebral Spinal, and they realized that there is circulating tumor DNA in the CSF that match the tumor DNA molecular pattern itself. So if you look at this first image that I have here, you realize that patient that has a negative circulating tumor DNA um, on analysis of the CSF, they tends to have a higher surviving compared to those that have a positive circulating tumor DNA. So if you look at that, they probably so what they do in the experiment is that they collect CSF samples from the patient, and they tend to measure the circulating tumor DNA in the CSF. And so they realize that along the line, patients that are circulating tumor DNA negative tends to have a higher range of survival compared to those that are positive. And they also show that if you look at this, this is they had a 10 low grade glioma patients, and they realized that about 6 of these patients share the same circulating tumor DNA with the molecular DNA of the tumor itself. So and I think this can really help in when we talk about genetic therapy. So I think probably sequel to their discovery in 2020, we have Peter DeBlanc and some others also who carried out another research on the molecular markers and targeted therapy in pediatric low-grade glioma. And what they do is that they treated the patient using selumetinib, and the outcome on treatment is that there was an overall survival of 10 years with 96% for pilocytic astrocytoma. So about 96%, and you can tell because like I said, pilocytic astrocytoma, they tend to have a worse prognosis when you compare them to leukotriema. So, but on treatment, you realize that there is a 96% survivor and about 85% in other low-grade glioma. So, and on treatment, also they realize that about 40% of the patients come out with a better outcome, especially among those that has neurofibrosis type 1 than in children that just have a low-grade glioma. So it tends to appear that this drug tends to work more in patients that has neurofibromatosis type 1. So as of our 2020, selumetinib was approved, and other drugs such as trametinib, binimetinib, and cobimetinib are currently under clinical trials to know if they are actually effective in the treatment of low-grade glioma. So the key takeaways from this presentation is that low-grade glioma are slow-growing tumors, and they are commonly found in children, and usually we tend to have an IDH type 1 and IDH accelerated dehydrogenase 1 and 2 gene mutation is commonly found in our patients with low-grade glioma, but we can also have other mutations such as the short arm of chromosome 1 and long arm of chromosome 19 co-deletion. And generally, this patient presents with seizures and headaches. And like the diagnosis most of the time might not be straightforward and might involve series of investigation. And the treatment is individualized based. And the goal is to increase the overall survival and to reduce the declining neurological deficit. So the idea of genetic therapy might actually be a more effective way of treating this patient. So these are some of the papers I consulted. You might want to go through them for further study and comprehension. Thank you very much for listening to my presentation.
Wow. Thank you so much, Tunde, for this great presentation. It was really wonderful. Thank you so much for your time and all the effort that you put in preparing this presentation. Like I have mentioned, it was really great. It was so wonderful. I'm going to open it up to the panel if there's anyone with something to say or if there's any additional question for Tunde.
Thank you very much, Tunde, for the presentation. It was marvelous. Really, it was really good. I have some comments and one question. From my comments, when you were presenting the case, like because this patient is a patient that raised intracranial pressure, but at the level of your investigations, you were like the way you were presenting, like you were insisting that you are kind of good that the patient has a lumbar tap down. But for me, I don't think like with this kind of patient, the fact that the patient has because we also the MRI that there was kind of it's true there was not like typical midline shift, but there was kind of a little bit of a different event. So I think for this patient, this will be kind of a contraindication for a lumbar tap. Even though for sure it will help us rule out differential, but I think for this patient, yeah, there will be an absolute contraindication.
Okay, Wapres, your voice actually was breaking. I could not hear you clearly, but if I get what you are saying, you are trying to say that having a lumbar puncture is contraindicated in this patient because of the high intracranial pressure, right?
Yes.
All right. I get that, but I'm sure to have you probably have to first manage the patient the intracranial pressure before you actually go ahead with the taking the CSF sample. So you can't actually take the CSF sample on that I don't know you get what I'm trying to say.
Okay, yeah, okay, I get it. Uh, also, at the level of the where you try to elaborate about the pronator drift, and you mentioned that the pronator drift is present when a patient
Yes.
has that's a pyramidal syndrome. But actually, for me, what I know is that that is the most common cause of it, pyramidal syndrome. But it can also happen to in patients who have cerebellar disease, or maybe you have a loss of proprioception. Because usually for with cerebellar disease, the pronotal drift is usually kind of upwards instead compared to the other one. And in case of yeah, said so that you could also have it in with patient who has loss of proprioceptive sense.
Okay. I think I made mention of the fact that prenatal drift actually indicates an upper motor neuron lesion. So if you look at the location of the tumor in this patient, so it occurs at it tends to it's closer to the frontal lobe and it actually affects the supplementary. And don't forget that the corticospinal tract actually arise from this region of the brain. So it could be as a so this tumor are not aggressive, they are slow growing. So and it tends to have a small max effect. So that's why this patient comes down with a mild prenatal drift. So it's actually an indication of probably a mass effect on the corticospinal tract. I don't know if I'm saying if I get you right. So and the fact that you made mention of that it could also be a sign in a cerebellar disorders. I think so.
Yeah. Okay, now my first question, like, because throughout the presentation at level of the imaging, like it's like you emphasize more on the MRI. So I want you to know, is it that maybe with a CT scan, like maybe a CT scan will actually give you no idea of what is happening exactly in the brain. You know that, like I, for example, also we're in a low resources setting, whereby in case you suspect any raised intracranial pressure, the first thing you going for is CT scan. Like before now, in case you might see if you need the MRI. So I wish you know, is it that maybe a CT scan like will give you no findings?
Okay. Like
I
like
will answer that question. There's very little. We need to make a difference between what we do because of availability and what is the actual benefit of certain examinations. So what difference do we have to make? First, you have to ask yourself, what is the sensitivity and specificity of a CT scan for a certain disease? If you're asking for a CT scan because you suspect a blood products within the skull, then you have a very high likelihood of being able to diagnose that. Now, if you're thinking about something like a tumor, or very often then CT scans will not help you very much to come up with the diagnosis. But you can ask a CT scan perhaps if you're thinking, maybe I can get an idea of where the tumor is and maybe indicate a biopsy. But do not make that become some kind of a general rule, right? So we're in a low resource setting, yes, but things are going to change eventually. Probably by the time you finish as a neurosurgeon, you probably find yourself working in a hospital that has an MRI, at the very least, an MRI. If that is the case, then you need to be aware of what you should be doing in terms of workup for neuro-oncology. You should be asking very often than not, you should be asking for an MRI because it will give you much more information. Now, if a patient doesn't have money, yes, you might say, okay, maybe we can get a CT scan and try and work off of that. But other than that, the best way to go is to get an MRI at the very least.
Okay, thank you very much, Dr. Ulrich. Thank you very much. That's all I have for now. Thank you once more again for the presentation, Tunde. Thank you very much.
Is there anyone with anything else to say? Any further questions or additions?